All right. Hello there. Good afternoon and welcome to Ask the Docs, a Fertility Institute of Hawaii live stream. This month, our topic is preeclampsia, both in the preconception and pregnancy period. Thank you for joining us today. We have a lot of great information to share with you today. My name is Dr. Emily Goulet, and I am here with our special guest, Dr. Janet Burlingame, who is a maternal fetal medicine specialist for high-risk obstetrics. Thank you for joining us today.
Thank you for inviting me.
Absolutely. So let's get started. Let's talk about what preeclampsia is. Is a lot of our patients who are just tuning in, they've never been pregnant, they may not be familiar with what preeclampsia is. So what is preeclampsia in general?
Well, it's a disorder, hypertension-related disorder that's unique to pregnancy. So you have to be pregnant to get it. And there's a lot of theories on what causes it. It may have a lot to do with the placenta because, in fact, interesting tidbit is you can actually get preeclampsia even if you're pregnant without a fetus, but just a placenta. But in any event, the classic triad that people talk about is high blood pressure, swelling, and protein in your urine. Although that's the more traditional diagnosis. It has changed and developed over the years. And I think the most recent notice by the American College of OB-GYN was in 2021. I think that was the newest revision. But anyway, long story short, your blood pressure starts to go up in the mild forms. You tend to retain fluid, even in your face, not just in your feet, but your face and your hands. You can have protein in your urine, but you don't have to. And there are also severe forms where it can involve what we call the end organs or the other organs in the body, like the brain, the heart, the lungs, the platelets, the liver, the kidneys. And in the very worst form, or that you may have heard, is the term eclampsia, which is where it can cause seizures, which unfortunately is rare. Less than 1% of people with preeclampsia will get eclampsia.
So certainly a topic of concern then when it comes to pregnancy, because this is something that all obstetricians are on the lookout for, and there may be risk factors in the pre-pregnancy period, which we're about to talk about here, as far as things that we can do to help minimize the occurrence of preeclampsia during pregnancy. Now, not all of the risk factors are modifiable, but there are many things that we know that can predispose a woman to developing preeclampsia in their pregnancy. Preeclampsia as incidence is 2 to 8%, I think, depending on who you want to quote. So about 5% of women is typically what I say. So perhaps 1 in 20 women may be affected with preeclampsia or one of its variations throughout pregnancy. So I think in general, we consider preeclampsia a spectrum of disorders. On the severe end, we have the eclampsia with the seizures. We can have the severe preeclampsia with other end organ problems like the platelets or the liver. We can have a milder type of preeclampsia where delivery might be needed earlier rather than letting the baby come when it's ready to come at its due date. And then there's even milder forms, I think, when it comes to gestational hypertension and whatnot. So risk factors for preeclampsia. What are some of the things that make us think a woman might be more inclined to develop preeclampsia in their pregnancy?
There are a handful of things. Some of the more common things, especially that we see in Hawaii, is already having high blood pressure or diabetes. Those are 2 of the more common risk factors. Older moms and very young moms are also more at risk. Any type of kidney disease, whether that be from diabetes, hypertension, or lupus. And lupus itself is a risk factor for preeclampsia. Having had it in a prior pregnancy is a risk for it. And there's probably even increased risk if you have a family history like moms or sisters. who've had it. Some people would say that IVF can also be a risk factor. Now, whether that's the IVF itself or the fact that women getting IVF have some of these other issues is a little unclear to me. And another common thing is not just type 2 diabetes, but even gestational diabetes. So often, and up to about 10% of women in Hawaii can have gestational diabetes. So I usually recommend my moms who have elevated sugar during pregnancy also monitor their blood pressure closely, because that's a kind of, I won't say overlapping, but we may think, the researchers think that some of the underlying conditions that predispose you to one predispose you to both, kind of an inflammatory response, if you will.
Yeah, that makes sense. Referring back to what I was touching on earlier, why preeclampsia is something we're on the lookout for. You already mentioned some of the more severe things, the seizures or the platelets and the liver problems, but it can cause problems for the baby as well, correct? It can cause needs for the obstetrician to intervene and say, okay, it's time we get this baby delivered sooner rather than later.
Yeah, absolutely. And again, it's probably related to the placenta and some type of abnormality of vasculature or the blood vessels in the placenta. So we tend to see smaller babies. In fact, sometimes we'll see a small baby before the mother's blood pressure is even elevated. So again, when I see small babies, I ask the moms to check their blood pressure more frequently. You can also see something called a placental abruption in severe forms, which is where you have bleeding because the placenta tears away or lifts up from the edge of the uterus. In mild forms, you can be hospitalized and monitored for that. But in the severe forms, it can actually lead to a stillbirth. So that's something to watch for too. Those will probably be the main two things. And then, of course, prematurity, because although it may not cause preterm labor itself unless you have bleeding, to help the mom and prevent long-term problems for the mom and long-term problems for the baby. Often the obstetrician will recommend that the baby get born early because moms don't start to heal from preeclampsia until they're delivered. So you can temporize or you can manage blood pressure. You can watch moms closely at home or in the hospital. But if it gets to the point where it's getting dangerous for mom or baby, then the only treatment is delivery, which regardless of how far along you are in the pregnancy.
Gotcha. So delivery of the baby is the ultimate goal, the ultimate treatment. But if a woman is developing preeclampsia and there are elevated blood pressures that make us suspicious for the future development of preeclampsia, is there anything that we can do in the pregnancy itself once the woman is pregnant?
Well, we've been looking for a lot of things. People have looked at vitamin C, vitamin D, vitamin E, calcium, low salt diet. None of those have really been shown consistently to prevent preeclampsia. There have been some trials as well looking at cholesterol lowering drugs. And I think it was just published not too long ago that showed that probably isn't as helpful as we thought it might be based on lab work. The biggest thing we have in our armamentarium, if you will, is trying to prevent preeclampsia from happening versus treating it once it happens. So whatever that phrase is, an ounce of prevention is worth a pound of cure. And there's been some nice data over the last 10 to 20 years looking at low-dose aspirin. Typically, we want it to start as early as 12 weeks, but ideally before 18 and certainly 28 weeks in women who are high risk. And the United States Preventative Task Force actually has kind of a nice chart or algorithm on who they recommend to take aspirin. And certainly in women who've had preeclampsia in the past, especially if it was earlier in pregnancy, not at full term, and there were complications, they recommend starting taking aspirin 81 milligrams to 162 milligrams at bedtime. And we don't really know why, but the studies show if you take it at bedtime, it works better.
That's
Something to do with the circadian rhythm, which is kind of a little nuance. But so a lot of it is identifying people early in pregnancy or prior to pregnancy, especially if they're about, it's a planned pregnancy, to identify those people and start them early. And in some studies, it's decreased the risk by almost 30%, which is about as good as we've gotten. And
Yeah.
unless you're allergic to aspirin or have really bad asthma, it's safe to take.
So this is the one exception, even though doctors are always very proactive early on in pregnancy, telling their patients no NSAIDs, no aspirin. This is the one exception where a low dose of aspirin may actually be beneficial for select patients.
Yes, correct.
And, for our infertility population, particularly those patients of ours who are undergoing IVF, many of those individuals are started on aspirin for infertility reasons at the time of transfer. And so many of our patients will be on the low dose aspirin at the time of their transfer when they get their positive pregnancy tests. And based off of their risk factors, will often be advised to continue that low dose aspirin throughout their pregnancy and with their transition to their obstetrician or MFM as they progress in pregnancy.
Which is great from my point of view.
Fantastic.
Often I don't meet women until 20 weeks when they're getting their anatomy scan. And the earlier you start the aspirin, the more likely it is to be effective. And in fact, European studies actually found better effect if you used 162 milligrams, which would be 2 baby aspirin.
Okay, that's very helpful to know. Along these lines, I get a lot of questions with my patients about things that they've read on the internet. Maybe they should be taking, or someone told them that they should be taking over-the-counter magnesium supplementation. Has that been shown to help with anything with preventing the progression of preeclampsia?
No, it's more likely to help with headaches. And you could argue in a circuitous kind of manner that women who have another risk factor for preeclampsia is women with migraines with auras, and magnesium can help women somewhat. It's not as strong as some of the other medications out there, but that would really be the only connection that I could find. Magnesium is used to prevent seizures, but the oral doses that you take aren't high enough to prevent seizures. The magnesium that's given to prevent seizures is given either in injections or more commonly through an IV.
Very, very true. I think that's a good segue into talking about what our patients, as they are progressing in pregnancy, what they should be on the lookout for concern about whether or not they themselves are developing preeclampsia. What are some of the red flags and the warning signs that would advise us to tell our patients, go to labor and delivery, go to your OB and get an evaluation done?
Sudden onset and swelling, especially if it's in your face or hands. I mean, a large portion of pregnant women will eventually get swollen feet and ankles. Not to say you shouldn't get that looked into, but especially if, over 2 or 3 days, all of a sudden you become very swollen, especially your face. If you noticed a decrease in your urine production or headaches that just won't go away, abdominal pain that's almost like someone was putting a belt just right under your rib cage and squeezing it, or bad nausea or vomiting. A lot of people sometimes will confuse it. We'll just write it off because they say, oh, it's my reflux disease, or I've seen some people attribute it to gallbladder pain, even chest pressure, trouble breathing is another one, trouble catching your breath, but probably the most common ones we ask people to screen for: change in vision, nausea, vomiting, abdominal pain, headaches, sudden swelling, and decrease in your urine output.
Great. And then if you have a blood pressure cuff at home, it never
Absolutely.
hurts to take your blood pressure at home as well.
In fact, I was just telling another family, I was like, almost everyone has a thermometer at home. And I would argue that a blood pressure cuff is just as important for every family to have. It's not just in pregnancy that it's useful. So, $30 or however much it's going for on Amazon may be just worth it for every family to have one.
On the flip side, especially here in Hawaii, where we do have a very big, um, uh, we place a lot of value on letting things be natural and continue the course without significant intervention. This is one of those circumstances, though, where leaving things to its own devices and letting a baby decide when it's ready to be delivered, this might not be the best thing to sit on at home and not get looked into, correct?
Absolutely. I mean, there's a subset of women who can be managed at home, but if they are being managed at home, they have a milder case. And there are also women who have access to care that they can get in at least weekly to see their provider, to be evaluated, have the baby evaluated, maybe even draw blood work once a week. But if you have the severe form or certainly even eclampsia, the recommendation would be to be in the hospital under close observation, because it can change overnight. And so you can be in the hospital feeling well one day, and then the next day, everything goes wrong.
So is it a pretty safe assumption to tell our patients then, if their term, meaning if they're at least 37 weeks and their blood pressures have creeped up into this range, that they should be talking to their OB and preparing for delivery sooner rather than later, rather than waiting till the baby wants to come 41 weeks past due?
I mean, they've shown in a fair amount of studies now, including a famous one that was done in Scandinavia, I think it's called the Hippotat trial, but that even without proteinuria, even just having elevated blood pressures, if you go beyond 37 weeks, you see a higher rate of maternal seizures, admission to the NICU, poor outcomes for the baby. Because you can imagine, even if the baby's doing well, and it's the mom that mostly has the symptoms, if the mom gets more ill, then the baby's going to get sick too. So staying pregnant for the sake of the baby is not often the wrong way to approach it. The baby will do better in the nursery on breast milk than its mom fighting an uphill, battle with all these symptoms. So the mild cases we usually recommend get delivered at 37 weeks, and the more severe cases you have to take individually, but in general, we recommend being delivered by 34 weeks. At that point, it's kind of a risk-benefit ratio, but by 34 weeks, most babies do really well. They need a little extra TLC, maybe be in the hospital for a few weeks. But the vast majority of them do pretty well.
That's good to hear. That's one of the wonderful things about our modern medical system here, is that we are able to offer a lot of support to both our babies and our mother. After delivery, can preeclampsia be associated with any other long-term health consequences? Anything else that we need to worry about for these mothers? Certainly, if they've got migraines with aura, we would want them to be managing that to try to reduce the numbers of migraines that they have. I think together there is some indication that those individuals may be at a higher risk for things like a stroke later on in their life. Are they at risk of anything else long term?
Yeah, cardiac disease, both cardiomyopathy, but also angina or coronary artery disease, hypertension, long-standing hypertension, which of course is then associated with a whole host of other things like kidney disease. And it may even be associated with the development of diabetes, type 2 diabetes.
Okay, all right. So So not necessarily something that can be forgotten about after delivery has occurred, something that is important to share with your primary care providers and your OBs and your OB-GYNs throughout the rest of your care throughout your lifetime.
Yeah, it's a good part of your medical history. So if you go to see a new PCP and they're asking you, you know, have you ever had any health problems? I would bring up, you know, let them know if you've ever had a preterm birth, let them know if you've ever had surgery, but also let them know if you've ever had gestational diabetes or preeclampsia. Those are all things that can affect ongoing health care, whether you're pregnant or not.
Very true, very true. We have a question here. How can we prevent preeclampsia, or is there a way to lower the chance of having preeclampsia? It's a great question. I think that's what I was trying to ask at the beginning before I got distracted with my own questions. And as I was alluding to earlier, a lot of the risk factors we cannot change. There have been, for example, if this is your first pregnancy, or if you're very young, or if you are advanced maternal age going into pregnancy, those things are absolute. Those are not modifiable. I think that there have also been considered some medium risk factors for preeclampsia can be your race. So we know that African American women tend to have poor outcomes when it comes to preeclampsia, as well as individuals of a lower socioeconomic status. Those are things that we can't change, but I think being aware of those things and being open and discussing those things with our providers are very important, because having that conversation, making sure that it is on everybody's radar, is certainly a move forward. Now, other types of these risk factors may be modifiable. For example, being obese, having a BMI that is greater than 30, or having higher blood pressure, which may be responsive to weight loss or a low salt diet or medication therapy. Is it smart to get the blood pressure under control before one attempts pregnancy?
It is. The data doesn't necessarily show that will, unless you can actually get rid of your hypertension, it was related to other causes. Just controlling your blood pressure doesn't necessarily mean you decrease your chance of preeclampsia. Having said that, you do decrease your chances of the mom having other risks like strokes and heart attack from high blood pressure, but not necessarily preeclampsia. But definitely weight loss, controlling type 2 diabetes, getting your hemoglobin A1C down. If you have an autoimmune disease, conceiving during a time of without a flare or quiescence is also important. So let's say you have lupus, you want to get that as controlled as you can and work with your rheumatologist to make sure that your complement levels are better and your anti-DNA is low and you're not currently having a flare. Those are some of the things that you can definitely modify.
And one thing in particular, I think that is of importance for our fertility population, because we know that our fertility treatments can increase the risk of twins and higher order multiples. Those are definitely a risk factor. Twice the baby, at least twice the risk. And so for individuals who had who've had a personal history of preeclampsia, or who have numerous higher risk factors, really focusing on aiming for that singleton gestation, or really focusing on aiming for one baby at a time during pregnancy, is one thing that we can do to help minimize the risk of preeclampsia. That being said, the treatments that we do come with an inherent baseline risk of twins. The oral medications that we do are typically quoted at 7% risk of twins. But things like IVF, where we do embryo transfer, the American Society for Reproductive Medicine strongly encourages women to do a single embryo transfer with the goal of a singleton pregnancy to prevent some of the bad obstetrical outcomes, like having preeclampsia develop during their pregnancies.
I think that's an excellent point. Yes.
Yeah. Do you have anything else about preeclampsia that you would like to share with us or for us to be thinking about moving forward in the future?
I think just making yourself aware, identifying your risk factors, asking your doctor at your first visit if you would benefit, if you're one of those people who might benefit from taking low dose aspirin, investing in a blood pressure cuff and learning how to use it, regular exercise, healthy diet. Those are all things to do beforehand. And certainly if you know you're high risk to begin with, to get your medications under control, to be in the best health that you can be before getting pregnant.
I think preeclampsia is rising more and more in our society's presence and mind. You know, we're seeing celebrities now like Kim Kardashian. I think she famously delivered her first baby because of her blood pressures rising in that pregnancy. And pop stars like Beyonce have come out, you know, that they suffered with preeclampsia during, she said, you know, she informed us of that with her twin pregnancy that she had. And so certainly this is something that is common, that nobody is per se immune from. Anybody can be at risk for developing it. You can develop it even if you don't have any risk factors, correct?
Correct. Absolutely. It can be, you know, no family history, totally random. Yeah.
All right. Before we wrapped up with the preeclampsia, I wanted to ask you a little bit about your COVID study, since we've got rising rates of COVID happening again, and we still don't have the entire population vaccinated. I know we're still waiting on vaccines for those under the age of 5. And so there is always going to be this risk until we can come out with a preventative measure for everybody. Can you share with us a little bit more about what you're doing with your COVID study?
I personally don't have an ongoing COVID study, but from what I can tell you, the most common question I get about COVID is boosters and vaccines. And the recommendation, a lot of viruses, there are a cadre of viruses that pregnant women do not do well with. And kind of the classic ones are influenza, chickenpox, and now COVID, especially the Delta variant. But we know the data has all shown that people who get the COVID vaccine do better than people who actually get COVID in pregnancy. So if you haven't been vaccinated, definitely something to consider. And the mRNAs have showed no problems. And in fact, there's some really nice data that shows that the mRNA vaccines increase the antibodies that you make that also go to the baby. So if you, even above getting, a lot of people say, well, I had COVID, but it's kind of like, well, you might have had whooping cough or whatever, but you still get the pertussis vaccine. And again, it's to boost the antibodies that go to the baby. The CDC has not confirmed yet about a second booster for pregnant women, excuse me, unless they have, they're immunosuppressed or they have other risk factors, but that may change. What's something to consider? If you haven't gotten the booster or you haven't gotten the vaccine, I would definitely encourage pregnant women to do that. And if they do, unfortunately, get COVID, you know, invest in one of those finger pulse oximeters and a blood pressure and a thermometer to have at home so you can monitor your symptoms. Hopefully you just have a mild case. I think with Omicron and its variants, and also with more people being vaccinated, we haven't seen as many admissions to the ICU of pregnant women. So that's been good news, but you never know what variant is coming around the corner. So good to be prepared.
Certainly. And it's nice to be prepared too, because every woman who's just delivered wants to be able to protect their baby as well. And so encouraging caregivers and those who will be around the baby to also get immunized and vaccinated can help us cocoon and protect the baby from exposure from COVID as well. I know that for myself, whenever I have a new patient, I always ask them, have you had your COVID vaccines? Have you had your COVID booster? Have you had your seasonal influenza shot? And are you prepared to get it again later on this year when the new formulation comes out? And I think these things are important to think about ahead of time. I've noted that many of my patients are a little bit more nervous about getting immunizations once they become pregnant. And so I find that having this conversation at the very first visit is great, because for those women who do have a little bit of anxiety about having these shots in pregnancy, now's a great time to go get the booster, so that they don't have to worry about getting the booster until we come out with recommendations for a fourth booster in pregnancy. You can always get it done now, because that recommendation for the booster is open to the entire population for that third booster where vaccines are available for COVID. And so that can always be done in the preconception period. But I do believe that all of the current societies, including the CDC, the American Society for Reproductive Medicine, the Society for Maternal Fetal Medicine, the American College of OB-GYNs, they all recommend being up to date with the COVID vaccines as well as the booster.
I absolutely agree with you. And I feel comfortable telling pregnant women to get it. But again, if they're hesitant and they have the opportunity to get it pre-pregnancy, if that's more comfortable for them, then, absolutely. And same with influenza. And if you don't know whether you're immune to chickenpox or not, and you're thinking about getting pregnant, ask your doctor to do a blood test to see if you already have antibodies. And if you don't, you can't get the chickenpox vaccine while you're pregnant, but you could get it before or after.
I think a lot of, sometimes I've heard patients tell me, oh, well, when was the last time I saw chickenpox? They may not see chickenpox on a regular basis, but we as healthcare providers, we do unfortunately come across those individuals who have had chickenpox. We do see a high tourist travel rate here in Hawaii. Not every country immunizes their patients, or their citizens against chickenpox, and so it is present worldwide, and it is something that here in Hawaii we can continuously be exposed to.
Yeah, and I remember before the vaccine, I've been practicing long enough that before the vaccine came out and was used several times a year, we had women with chickenpox that were in the ICU on ventilators and really critically ill. So the vaccine has made a big difference, I think, just anecdotally.
Oh, absolutely. All right. Well, thank you so much for joining us today, Dr. Burlingame. I put you on the hot seat and I asked you a lot of really tough questions, but questions that are very important, I think, for the well-being and the safety of our pregnant patients moving forward. I really appreciate you joining us today. If those listeners out there who are tuning in, if you have any more questions, please don't hesitate to reach out to us. We're happy to investigate a little bit further and ask Dr. Burlingame what she thinks about those preeclampsia questions. But thank all of you for joining us today, and we look forward to seeing you next month.
Yes, thank you. And have a good summer. I guess it started.
Yes. Bye.
Take care. Bye-bye.